The highlights from ASCO 2022 in genitourinary malignancies, I wanted to highlight one trial in each disease space. In prostate cancer, we had pretty nice update from the TheraP trial. This was a phase 2 study of 177 lutetium targeted against prostate-specific membrane antigen, PSMA, compared against cabazitaxel, run by Dr. Hoffman and his colleagues, our colleagues in Australia. They had initially reported the primary endpoint of progression-free survival a few years ago at ASCO, and this was an update about overall survival for their population. So as a reminder, it was taking patients with metastatic castration-resistant prostate cancer and randomizing between lutetium versus cabazitaxel chemotherapy. And the update that we saw at ASCO this year was that there was no difference in overall survival between the two cohorts. Now, overall survival was a secondary endpoint. They had initially met their progression-free survival primary endpoint difference and shown a difference for lutetium over cabazitaxel. But on the overall survival, there was not an overall survival benefit, and both cohorts did well in terms of the 3-year cutoff. And the hazard ratio was right around 1. And what it really meant to us was that lutetium is a viable choice, and both of these options are good choices for metastatic castration-resistant prostate cancer. So a nice update from our Australian colleagues on the TheraP trial. In kidney cancer, we saw a primary endpoint analysis of a cooperative group trial called EVEREST. This was a trial looking at the benefit of everolimus in patients in the adjuvant setting, so post-op, high risk for recurrence of clear cell kidney cancer and of a small minority with non-clear cell kidney cancer randomized to either everolimus or placebo. And when the study started, there was no other standard of care treatment in the setting, so that's why placebo was used for the control cohort. And what we saw, the primary endpoint was recurrence-free survival, so time until disease recurrence. And from a high-level perspective, they did not reach statistical significance of showing a direct benefit of everolimus over placebo in this cohort. There was numerically some differences of the 5-year estimates, but didn't show their pre-specified statistical significant outcome. And the higher risk treatment group did show a small difference in the time to recurrence, although when they looked at the lower intermediate risk group, there was really no benefit at all. And so I think this is practice informing. We don't often give everolimus in the adjuvant setting. It's not approved. And it is certainly thought-provoking in terms of thinking about how we can add to our adjuvant space. We currently have approved either sunitinib or pembrolizumab for a year for patients with kidney cancer. And then finally, for bladder cancer, for urothelial cancer, we did have an update on the EV-301 trial. This was a 24-month update for enfortumab vedotin versus standard of care chemotherapy in refractory urothelial cancer. And what we saw was there was an overall survival benefit. Median OS was about 12.9 months for patients treated with enfortumab vedotin versus about 9 months for patients treated with chemotherapy standard of choice. Usually it was a paclitaxel or venflunine in the European countries. And so that showed the benefit of enfortumab vedotin and continued its label and indication for metastatic urothelial cancer in the refractory space. So those 3 trials I thought were very informative for our practices in GU cancers, and I hope these 3 trials continue to be used to inform our practices in providing life-prolonging therapies for patients with GU malignancies.